Okay, hello and good afternoon, everyone. My name is Jennifer Bell. I am a bioethicist and clinician investigator at the University Health Network, where I primarily serve as Princess Margaret Cancer Centre. This lecture is being co-presented by UHN Bioethics and the University of Toronto Joint Centre for Bioethics. On behalf of the entire team, I want to extend a very warm welcome to all of you today. This lecture is being recorded and will be archived on the Joint Centre for Bioethics YouTube channel. If you're a UHN employee, you will also be able to access the archived lecture on the UHN Bioethics intranet site. So today's lecture marks the 40th year of this Engaging Endowed Lecture series. 40 years. This lectureship was established at Princess Margaret by Bill and Pat Harris to honor their daughter Pippa, who in 1981 died at the age of 20 from cancer. One of the aims of the lecture, in addition to memorializing a remarkable young woman, is to serve as a catalyst for open and respectful dialogue with our community about timely and important facets of ethics in healthcare. Looking back at our previous speakers and topics, we have been fortunate to be able to host a very accomplished speakers presenting on a range of thought-provoking and timely topics arising in the context of clinical, organizational, and research ethics. Today's speaker continues in this impressive tradition and will be familiar to most of you owing to his fearless engagement with tough ethical issues in scholarly publications and in the popular media. We thank Bill and Pat Harris and their family and friends. They have made the Philippa Harris Lecture on Bioethical Issues in Cancer Care a much anticipated annual event. The structure of our time together will be as follows. First, we will hear Mrs. Harris's remembrance of her daughter Pippa and her reflections on the history of the lecture and today's topic. This will then be followed by Professor Arthur Kaplan's presentation, after which we will have a facilitated discussion moderated by our UHN Bioethics colleague, Dr. Andrea Bianchi. Please post your questions in the chat box at any time for the discussion. We would like to begin by acknowledging the sacred land upon which the University Health Network, where this lecture is being recorded, operates. For thousands of years, it has been the traditional territory of the Huron-Wendat, the Haudenosaunee, and most recently, the Mississaugas of the Credit River. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee Confederacy and the Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. Today, the meeting place of Toronto is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work and learn on this territory. We also stand in solidarity with the ongoing protests against racism and systemic discrimination and endeavor to work with our UHN colleagues and leaders to support efforts to advance equity, diversity, and inclusion. We will now play a video that Mrs. Harris pre-recorded with the assistance of her daughter, Pippa's sister Diana, and her family.
Hello, I'm Pat Harris, Philippa's mother. For 40 years, before many of these annual lectures, I've given a little story to illustrate Pippa's personality. Now, in the mid-1970s, my husband was booked to attend meetings in Nairobi. Just before his dates, our family planned a safari in the game parks. With four children, aged 6 to 15, Philippa's mother, we flew off to Africa. Poignant memories Hello, I'm Pat Harris. My husband was booked to attend meetings in Nairobi. Just before his dates, our family planned a safari in the game parks. With 4 children, aged 6 to 15, we flew off to Africa. Poignant memories signal the success of this adventure. For example, a few months later, I overheard Ginny, aged 10, on the telephone, correcting her school friend. "No, Peggy," she said, "the jungle is not like that." And the safari triggered Pippa's study interests. She decided that she would return to Africa to care for animals in the game parks. Then cancer altered her focus. She was determined to beat cancer and instead of wild animals, she would work to help cancer patients. But alas, this was not to be. Donations to a fund in Pippa's memory at Princess Margaret Hospital Foundation offered our family the opportunity to focus on Pippa's wishes. The history of these annual lectures, the selection of outstanding international scholars whose names are listed on panels in the hospital, astound each new speaker every year. Lecture topics focus on aspects of ethical issues facing medical staff, cancer patients, and their families. For example, to be informed about research funding, especially during a pandemic, to cope and adjust, face the future, and always to focus on hope. Today is the second virtual Philippa Harris lecture. Last year's lecture successfully attracted a much wider and larger virtual attendance compared to the space available in Princess Margaret's lecture theatre and overflow classroom. The virtual format offers the selection committee a worldwide field for superb, appropriate speakers. I thank the committee for their diligent research and persuasive lures. This year's speaker is the renowned professor, Dr. Arthur Kaplan. Thank you, Dr. Kaplan, for joining us today. Hello, I'm Pat.
Thank you, Pat. These are very moving reflections and a wonderful prelude to our speaker today. It now brings me great pleasure to formally introduce our speaker. Dr. Arthur Kaplan is currently the Drs. William F. and Virginia Connolly Mitty Professor and founding head of the Division of Medical Ethics at New York University Grossman School of Medicine in New York City. Prior to coming to NYU, Dr. Kaplan was the Sidney D. Kaplan Professor of Bioethics at the University of Pennsylvania Perelman School of Medicine in Philadelphia, where he created the Center for Bioethics in the Department of Medical Ethics. He also taught at the University of Minnesota, where he founded the Center for Biomedical Ethics, the University of Pittsburgh, and Columbia University. He received his PhD from Columbia University. Dr. Kaplan is the author or editor of 35 books and more than 800 papers in peer-reviewed journals. His most recent books are Vaccination Ethics and Policy with Jason Schwartz and Getting to Good, Research Integrity in Biomedicine with Barbara Redman. He has served on a number of national and international committees, and in order to preserve time to hear Dr. Kaplan speak, I will share a few from a long list of contributions and accomplishments, including his role as chair of the National Cancer Institute Biobanking Ethics Working Group, chair of the Advisory Committee to the United Nations on Human Cloning, and chair of the Advisory Committee to the Department of Health and Human Services on Blood Safety and Availability. Relevant to the topic today, Dr. Kaplan has served since 2015 as a chair of the Compassionate Use Advisory Committees, independent groups of internationally recognized medical experts, bioethicists, and patient representatives that advise Johnson & Johnson's Janssen's Pharmaceuticals on requests for compassionate use of its investigational medicines. Relevant to our topic during the COVID-19 pandemic, he is co-directing an advisory group on sports and recreation for the U.S. Conference of Mayors, created a working group on coronavirus vaccine challenge studies, developed an ethic framework for distributing drugs and vaccines for Johnson & Johnson, and helped develop rationing policies for NYU Langone Health and many other health systems. He's a member of the WHO Advisory Committee on COVID-19 Ethics and Experimental Drugs Vaccines, and he helped set policy for WIRB WCG, which is an independent ethics review service in the United States for research studies. He was an advisor to Moderna Incorporated, and he serves on the NCAA COVID-19 Medical Advisory Group. Dr. Kaplan received the Patricia Price Brown Prize in Biomedical Ethics for 2011. In 2014, he was selected to receive the Public Service Award from the National Science Foundation National Science Board, which honors individuals and groups that have made substantial contributions to increasing public understanding of science and engineering in the United States. In 2016, the National Organization for Rare Disorders honored him with its Rare Impact Award. That year, he also received the Food and Drug Law Institute's Distinguished Service Leadership Award and the American Society for Bioethics and Humanities Lifetime Achievement Award. In 2019, he was honored by the Reagan-Udall Foundation for the FDA with its Innovation Award. Dr. Kaplan holds 7 honorary degrees from colleges and medical schools. Without further ado, it is my great pleasure to now welcome Dr. Kaplan to present.
Hi, everybody. Thank you so much for honoring me with the opportunity to give this Harris lecture. It's really a pleasure to be able to do so. Thanks, Pat, for those remarks, and get to know a little bit about your daughter. And some of your remarks actually set up my talk, because I'm going to talk more about research ethics in cancer than therapeutic issues or palliative issues. And I very much appreciate that introduction. I almost didn't turn on my screen here to talk because I was getting so excited about all the many commendations you were giving me. But it's a pleasure, as I say, to be here. So what I'm going to do, I changed my presentation at the last minute, as I want to do sometimes. But some of you in the audience will know that NYU Medical School just announced, literally today, that it had performed a transplant using a pig kidney into the body of a person who was dead, but being maintained artificially on life support. This is a step toward trying to genetically engineer pigs and their organs so that they could become a supply of organs for transplant, kidneys, hearts, livers, when there is so much scarcity in Canada and the US in terms of people who need transplants but can't get them because there are no cadaver donors or not enough living donors available to meet the demand. So a very important experiment. Has some dimensions that I don't want to get into today about whether it's okay to genetically engineer pigs or to sacrifice pigs to help humans. But I do want to say a few words about this model of research on the newly dead, which I think is worth some discussion. And then I'm going to shift over to a different topic, which is what's the impact of COVID and research issues there that have come up on cancer research for the future. And I think it has, it's pretty clear to me that there are going to be moral changes, ethical changes in how we think about the future of cancer research, given what has happened with research to try and battle COVID. So you're going to get a 2-part talk. At the end of the remarks about research on the newly dead, I'll stop, take some questions, comments on that, and then we'll move on here, part 2, on the implication or the impact of COVID on our cancer research future, and then we'll have some discussion of that. You'll be pleased or horrified to know I don't like slides, so I don't have any. But hopefully I'll keep this lively enough so that you'll be able to pay attention to the whole Harris lecture. So let me go back and tell you about this experiment that we did at NYU just announced today. It's the first investigational transplant of a genetically engineered kidney from a non-human source to a human body. It was done actually September 25th, but collected data, monitored the results, preparing for dissemination of the findings by the research team. So they didn't announce it till today. A single kidney was used. The animal, in fact, wasn't sacrificed yet. It will be, I think, as part of the follow-up study. But it was procured from this genetically engineered pig, which is on a facility that genetically engineers, breeds, and makes these pigs hundreds of miles away. So the kidney had to be helicoptered in to NYU, into New York. And it was transplanted into a person who had died, absolutely pronounced dead by an independent group, no violation of the rule that the people who treat the individual and pronounce death should have nothing to do with transplant. When it was transplanted, that individual was still on life support, so it was an instance in which brain death had occurred. As many of you know, it is possible to maintain circulation and breathing in a brain dead person for some period of time. Some individuals, in fact, have delivered babies who have died post-mortem, being on life support for many months. So how long it could go on, we don't know, but certainly it is something that can be done to, if you will, maintain the integrity and function of many bodily organs when the brain has ceased to function. So what I want to get at is, who was this person who acted as the subject upon death, and say a word too about why did we decide to put this pig organ in her, and do so for about 50 hours, studying whether the kidney would be rejected as foreign tissue by her body rapidly, and whether the kidney would make urine and act as a kidney needs to if we're going to get in the future to using those organs as transplantable organs. So we had undertaken a study some years before, because my idea was maybe it's possible to use newly dead persons as subjects of research in dangerous experiments. That is to say, instead of saying we're going to use a living person in an early study, for those of you who know this language, a phase 1 study, and expose them to something that might be very dangerous and potentially could kill them, organ rejection, maybe we could use a newly dead person. Now, this had been discussed, and I will confess, one of my former mentors, a doctor named Willard Galen, long ago when I was at the Hastings Center, probably, I can't remember the exact date, late 70s, maybe early 80s, had written a provocative article in the New York Times Magazine about the possible use of the newly dead, he called them neomorts, in research. So I can't claim to be the first person to ever think about the idea of using the newly dead. There was some discussion also of this idea by people at the University of Pittsburgh, but my idea was, let's really set up a system under which we could be secure ethically that the person who might serve to study after their death, we would be comfortable with all of the steps taken, and that we had not done anything to violate anybody's interests pre-death or do anything to desecrate or disrespect the body post-death. So we met a working group and we came up with a number of ideas that we thought you had to follow. First and foremost, if somebody dies, the first object is to see whether they want to be an organ donor and to procure organs that might help save lives. It's very hard to say we're going to jump to a research study when somebody might have viable organs that could save lives. So one condition for doing this is that the individual cannot be an organ donor for whatever medical reasons. And in fact, in the case involved here, the person who died had cancer and was not deemed eligible to be an organ donor. Secondly, we wanted to establish that the person did want to be an organ donor if possible. And this woman did. She had registered for organ donation. Part of what that registration means is that if you can't be a donor for transplant purposes, it does say that you might be involved, at least your organs, in research studies to understand disease. So we have that as part of our organ donation consent. She had done that. She had done that with her family's knowledge. They were very supportive of the idea that she be an organ donor. Thirdly, just to make sure that we are dotting all the I's and T's here, we decided that to use this person in this way, which she had not known was going to happen, the family should give permission as well and say it was consistent with her wishes and values as best they could understand them. Family was absolutely consulted by our organ procurement organization. They obtained a very good, solid consent from the family, understanding what the proposed experiment was, using the genetically engineered pig organ to find out whether it might work, to find out whether it might be rejected and therefore really create a problem in terms of ever giving it to a human person who was alive. And they were absolutely sure that she would want to do this. They consented. They were very supportive of the whole idea. We then have to make sure that they're also comfortable with the study of the body by autopsy to see whether any impacts have happened that were not clinically observable in terms of putting this genetically engineered pig kidney into the person. So, a couple of steps just to remind you, looking for volunteers who want to help others through organ donation but can't because of their health or some technical reason, looking to people who are brain dead so that we might be able to support them technologically, artificially, set a limit, I forgot to mention, on how long this would go on, because you want the family to be able to come to terms with the death, have their funeral, have their grieving period, and so forth. So we said, look, no more than 72 hours at most. We can't prolong the study past that because we start to potentially interfere with the response to the death by family and friends. Make sure that the family is in total agreement with this, would be consistent with the deceased wishes, and make sure that we're in a situation, as I say, where we can comfortably say to others, this was something that was done altruistically, voluntarily, no pay, no motive other than a person saying, I would like to help post my death in advancing transplant research. But if you're with me this far, you can see where I'm going. This model might be used for other sorts of studies. We have a situation where you could set up other work, maybe cancer research involving high doses of drugs that you wouldn't want to start with in people or that you are nervous about, maybe different gene therapy vectors that people worry could be dangerous. This model could be used in other areas in order to try and understand high-risk interventions into humans instead of going the traditional route, for those of you who don't know, studying animals, then moving on to phase 1, either healthy volunteers or people with a disease that you're trying to see, is it safe to go there? Phase 2, trying to alter doses and look for some biological response to what you're doing. In phase 3, doing the traditional randomized placebo-controlled trial. Maybe between animals in phase 1, for certain high-risk experiments, we might create this model of letting the newly dead be used as subjects. If we agree with this, one thing I would say is we certainly want to change our donor cards. We certainly want to change our laws governing what you can do post-death to make it very clear that you might be an organ donor, and that would take priority at all times. You might have your organs studied. You might have your whole body donated if you wanted to do that for medical teaching purposes, which some people do, or within limits, you might volunteer to be a study subject post your death for some period of time. And again, with your family's permission and consent too, because again, this is an area where we want to respect the needs that the family has to come to terms with the death. So I think this model deserves more exploration in areas like cancer research, gene therapy interventions that are aimed at doing genetic modifications in terms of somatic cell disease and cancers, looking at other drug studies, and maybe others have other ideas, but it may open up a new window for research. So let me stop here, and I'll ask if you have questions or comments that you want to give me. That will be fine. I'll try to respond, and then we'll move on to another area where things are changing because of COVID, the general nature of research ethics and where we might go.
Thank you so much, Dr. Kaplan. And I'm just looking out for any questions or comments that people may have. In the meantime, I wonder if you could speak a little bit. I thought this is a very interesting initiative, and I very much value learning about it. I noticed at the beginning when you were mentioning this idea that you had of doing research on the newly dead, that you mentioned that it would be specifically for something like a very high risk phase 1 trial. And I was just wondering how you define risk, whether it is risk that where death is very likely to occur. What's the spectrum, I suppose?
Yeah, that's a great question to which I don't have a complete answer in all honesty, because it hasn't really been debated about risk eligibility. In this case, we knew putting in the pig organ, the chance of an immediate rejection, meaning the organ literally dies on the spot, would kill a human subject that happened to. So that was high risk. We knew it. The other kind of a risk is that you trigger some other biological activity in the output of the kidney or something, and that would prove lethal to the phase 1 subject. So this is way over. This is going to pass muster on most calibrations of how much risk is risky enough to go here. But I do think if we're going to push this model forward, we have to really come to an agreement on what are we talking about in terms of eligibility for enough risk. I have a feeling in cancer, it's things like very high doses. You're not sure, could they be tolerated? So normally, you're sort of going slow in phase 1, try a little more, try a little more. There's a negative response of some kind, that's too much. Here, you might be able to proceed faster and at higher doses and eliminate that sort of titrated incremental process that often winds up being used in various types of drug and infusion studies. So that's an area where I think saying, okay, well, what is really risk enough is worth arguing about.
Thanks so much for that response. And we do have a couple of additional questions. So one is from Jeff saying, hi, Dr. Kaplan, thanks for this excellent talk. I was just wondering if you had an ethical justification in your back pocket handy for conducting research on the newly dead. Many thanks.
Yeah, I think my argument again is reduce risk exposure to vulnerable subjects. Look, there are many people out there who are so desperate to get a transplant of any kind that they would say, you could put the pig organ in me and I'll take my chances first. And I get that. Or whatever it is, the pig liver, a pig heart. Many of them face dying. They know what the odds are on the US, and I might add, Canadian wait list. There's a lot of people who just don't get an organ and die. So in this space, it does seem to me trying to move the technique forward rapidly, taking, if you will, I'm going to call it phase pre-1 on the newly dead approach, does give you the possibility of saying this is what we might say proof of concept. It could work. Now, obviously, you don't want a kidney that works for 3 days and then fails. So we don't have all the answers. Somebody's still going to take a lot of risks down the road if this works. But it does seem to me in my back pocket, I can say, big demand, huge problem, dangerous. Never really did it, don't understand it, try to do cross-species studies, pig organs into baboons and this sort of thing, but you just don't know. So that's how I would respond, saying, I think this setup, I've never had any problem, but I'll tell you a little inside baseball on this one. The inside baseball is, we pushed the idea forward of the ethics of using the newly dead in a paper that came out 2 or 3 years ago, which I'm happy to share with anybody who wants it. I just posted it on Twitter, by the way, if you follow Twitter, it's just at Arthur Kaplan. And we were the people who led our surgery team to start to think about it. In other words, they didn't come to us and say, hey, how about the newly dead? We'll test this on them. This is an example for bioethicists here of the ethics trying to lead into saying, here's an innovation that you might want to think about. A lot of people view bioethics as just a place that says, no, I've jokingly said in my career, if you want to be a bioethicist, you just learn to say, no, you can't do that. That's too risky. Don't do it. Don't do it. Don't do it. Here's a situation in translational research where we came up with an idea, tried to lay out the infrastructure for how to apply it, talked about it with our transplant people, and they said, I think that's going to work. Let's do it. So this is a case where we were in the lead, I'm telling you, by year at least or two, before our transplant guys actually said, yeah, we're going to actually conduct this experiment, get the IRB approvals. I didn't say this, they actually asked the New York State, where the school is, Board of Health, if they were okay with it. They probably didn't have to, but they were, they checked around, if you will, a little bit. The Hastings Center had a little discussion, I know, with the group, because, we're inside, so people might say we're conflicted. We're kind of working with our team. But they tried very hard to, as best they could, set up, ethical approvals. But I'll come back to this point because I don't want to lose it. I'm a big believer, and always have been, that sometimes bioethics takes the lead and points to something that might need doing, rather than responding all the time or being reactive almost after the fact.
Thank you so much. And I very much value hearing that as well as a bioethicist, and learning that your team really took the lead on this very innovative initiative. There's a couple of additional questions that came in, Dr. Kaplan. So one of which is from Anne, just saying, can't we do this under existing donor consent rules, or is this stretching the interpretation of donation for research a bit too much?
Yeah, that's a very good question. I think you probably could do it legally in the US under our law governing organ donation, because it does have this research component, and there are people who come along and donate their whole bodies for study in medical school. By the way, not as common as it used to be, but they're starting to use, virtual stuff that makes it a little easier. But we have the tradition, and it still does go on, of somebody saying, I donate my body to dentistry study for students to learn and learn their anatomy, or I donate my whole body actually for strange purposes like studying automobile accidents where they use cadavers to see what damage happens. So that's all there. And in a way, this is kind of a continuation of, if you want to put it that way, whole body donation. On the other hand, I don't mind if we modify the existing laws to include research. Do you want to volunteer for that? I don't want the public to think I don't trust it. I think they're doing strange things with people. There's always this danger that someone out there is going to have read Robin Cook's book from long ago called Coma. That was a book about maintaining people, I think they're alive, not dead, but in any event, maybe permanent vegetative state in big warehouses where you'd go and study them. That was actually the Will Galen idea too, way back in the article that he did that I mentioned in the 70s. We want to maintain public trust. My answer would be whatever it takes to maintain public trust, I'm good. I don't have any reason to hide it. I think some people want to do it. How many people you need ultimately, if this really took off and we used it in cancer research and other research settings, I have no idea. I don't know, but so I'm a little bit inclined to lay it out.
Thank you so much. It would be very interesting to learn about how or whether the public does trust this kind of research.
This is a survey. Yeah.
And actually related.
By the way, sorry, Andrew, that's just one comment. We did do some surveys a couple of years ago on face transplants, because we remember NYU did that too. We're like transplanting lunatics, I guess, at this point. But so that's why ethically we have a transplant ethics working group. We're talking all the time to the transplant people. We know what they're thinking about, and that's great. But the point that I was headed to is a lot of people get nervous about donating their face. And to that list, as many of you will know, has been added uterus, limbs, larynx, testes. So you're getting into reproductive parts. Anyway, the survey showed that many people were comfortable donating livers and hearts, but they were not comfortable donating a face. And if they thought by signing a donor card that they would become face donors, they wouldn't do it. So that's an area where the surveying is important.
Thank you so much. Are you okay if we do just a couple more questions and then
Sure.
you can mosey on
Yep.
to the second
Yep.
to part two? All right, sounds good. So a couple of additional people seem to find this topic, namely research on the recently dead, to be fascinating. One person asks whether or not this is actually happening outside of the US, to your knowledge.
No, not to my knowledge. The only other instance, and I have to admit a dim connection to it, way long ago when I was in Philly, they were trying to develop an artificial heart, kind of like early days total artificial hearts, not the left ventricular assist devices. And I do believe secretly somebody tried one in a newly dead body at Temple University. So they didn't make a big deal out of it. They were like, let's do this on the sly. I don't know whose permission they got. I don't know. Maybe they got it, maybe they didn't. That's the only other instance that I know of.
Great, thanks so much. And perhaps time for one more question at least. So one person asks, how do we handle competition on the newly dead as they serve as organ donors? So I guess that's the one kind of thing that we would value people for after they die, to ensure we do have these organs, versus as experimental subjects in the newly dead approach to science, is how this person phrased the question.
Yeah. Well, my answer is the current system for donation presumes that you're going to save lives by giving your organs, and that has to be honored. So I don't even see it as right now in doubt. Transplantable organs, you're not going to be used as a newly dead subject. Organs are going to go to whoever needs them, and you're going to try and save lives. And I think that's what the donor system is intending to accomplish. So I don't mean even to get into an argument. Maybe the scientific use could save more lives if we studied cancer drugs or something else, and people said, look, I could save 1,000 lives if you let me experiment. That's a social discussion that we would have to debate about changing the whole nature of why we permit organ donation, what we think organ donors have in mind. But I know when I talk to people, students and others, when I'm asking them are you an organ donor and why are you? They say, yes, I am, because I want to save lives. So that's first and foremost on their minds. If you're honoring their intent, and it is a gift, right? We're not in markets yet. You've got your priority pretty clear. So that's going to take a big social discussion to say, no, I don't want to do that. I'd rather be a newly dead experimental subject first.
That's incredibly interesting. Just given the time that we're at, I wonder if perhaps Dr. Kaplan, you'd like to move on to part
All
two.
right.
And,
by the way, when I get done, we can talk about this more or other crazily provocative things I'm going to tell you about now. You're getting the big shifts in clinical research ethics thinking today. All right. So COVID. One of the things that has happened there is people have heard and know that things have moved for drugs and vaccines at warp speed, right? This is very American, but it's spread around the world a bit. People called the project to develop vaccines for COVID in the US, Project Warp Speed. That term was used frequently. It has set off some negative things. Some Americans think, wow, I don't want something that was made at warp speed. I'm not sure that's safe. I'm not sure that's something I want to have put in my body, particularly around vaccines. So it may have done some damage, but it also perked up the ears of many people who have been frustrated by the inability, they think, of research to get to their problem quickly. So many groups are watching what's going on with rapid approvals in the US, but in other countries too, the UK, of vaccines and drugs for COVID, including groups like Alzheimer's, ALS, and many cancer patient organizations, both for adults and for children. They're watching closely, and what they see, just to give an example, approval of COVID vaccines that normally, for getting through the whole if you will, regulatory approval scheme here, Canada, UK, would take 10 years. You have to organize your animal studies. You've got to recruit your subjects for initial phase 1 studies. No one's using the newly dead here. Then you've got to recruit big numbers into randomized trials down the road, hoping that they get exposed to whatever the disease is in sufficient numbers so that you can see whether the vaccine is doing anything preventative or prophylactically. Long process. We get into COVID, all of a sudden we got vaccines in a year that worked well, right? Very efficacious, really very safe. Whether people have misinformation about that, the fact is they work very well. The Moderna and Pfizer vaccines had efficacy rates initially determined to be around 95% in preventing death. That's just incredible. Vaccines normally don't get to that level of efficaciousness and safety. So these groups, and cancer groups too, are saying, you got that done in a year. I am dying of whatever cancer, or my child is dying within a couple years of whatever cancer. Where the hell is my warp speed? What's going on here? How come the world, when you cared about it, you went fast and developed something hyperspeed or warp speed, but for us, you're telling us we can't do that. They also, I have to say, were watching many of the patient advocacy groups in the US and around the world. Pre-COVID, they looked at Ebola. Didn't have the same attention, but you'll recall, maybe some of you, that Ebola broke out. Some doctors and nurses were over there from rich countries in places like Sierra Leone and Liberia, caught Ebola, were brought back here, and they were given unapproved drugs, the kitchen sink. Did they work? I don't know, but people didn't say, oh, you have to organize everything into a trial, and we're going to have phase 1, phase 2 studies before we organize. They just said, this guy's sick. I don't know what the heck to do about Ebola, but let's try these drugs, and let's try that drug, and let's try this plus standard ICU care, whatever. Some people may have gotten better on their own. Some people may have gotten better from interventions because there were actually no studies really well done. It's hard to know what might have worked as treatment. And people were also developing at fast speed an Ebola vaccine and cutting out some of the steps there that normally they would have required to get the thing approved. So the patient groups in cancer and elsewhere know this. And they had started to press pre-COVID for greater speed for their disease. In the US, we had a whole movement, which has gotten a little obscured, but before COVID, many people here were yelling for something called right to try. They wanted legislation enacted that would give somebody who was terminally ill or dying the right to use a drug without FDA approval or intervention. If they could get it from the drug company, they should be allowed to use it and not have to worry about if it went past phase 1 studies, I should say, and not have to worry about anybody else's approval or intervention. They're in trouble. They should get this. And that law passed in about 42 or 3 American states. And there's a federal law that former President Trump, former Vice President Pence frequently talked about, were very proud of, as saying that they had sped up the research process. Now, in Q&A, we can talk a little bit about whether those laws actually did anything. They didn't. They didn't help hardly anyone get access to anything. And I'll tell you why. It's because the sponsors don't really want to give away stuff without the FDA being involved. Oddly enough, they find FDA to be protective of liability and things going wrong. And some of them just don't want to give away their drugs to people who are desperately ill because of cost and other factors. So basically, despite these laws, they didn't work. But the spirit is what I'm interested in. Speed up the process. And coming back to COVID and its impact, people are saying, we see what you did, by the way, with drugs and vaccines in terms of getting them out there. We want that done for our disease. One other thing that was done with vaccines, you may remember, people wound up at the FDA under the advice of advisory committees invoking emergency use authorization. So that is an authority that the FDA has to basically give approval based on incomplete data to the availability of a drug or a vaccine. People forget there's a condition. It says emergency use. It means this FDA thing has to be invoked by the FDA if there's a declared public health emergency or some form of national security, like an anthrax attack is planned on some base or something like that. It's almost never been used historically, by the way, in the US, 7 or 8 times. Use for something like this kind of a pandemic was unprecedented. And by the way, when people say it was invoked using incomplete data, that's true, but they had a mountain of data, even if it didn't have a lot of data over a long period of time, but they certainly knew safety and efficacy, waiting for data to come in after 2 shots and 6 months, 7 months, 8 months of exposure, when most vaccines will show their side effects, by the way, anyway. So they were quite ready to say, with people dying all over the world, with people dying in droves, with no treatments, all we've got is quarantines, masking, testing. We're shutting down cities. Not only are people dying of COVID, but we've got psychosocial havoc going on among our children and adults, and the economy's teetering, and that is killing people ultimately too. We're going to take the evidence we've got and give emergency use. So, cancer groups looking at that, they say, we've got an emergency. My child is going to be dead in 3 years from some horrible terminal illness, and I want you to behave the same way. Use evidence, but be ready to take promising evidence and respond to my emergency. Now, emergency use authorization would not, as it reads in the US, be applicable to what I just said, but the patient groups are starting to say, make it applicable. An emergency from COVID is not very different from a family struggling to deal with all forms of horrible cancers and other neurological diseases that ravage children. Let us have our emergency use authorization possibility too. So again, just to recap, in COVID, we saw many people say, we've got to speed up the normal process. Boom, out come vaccines. Took far less time. That's great. We see many drugs getting emergency use authorization. By the way, I'll get to this. Some of them didn't work at all, but nonetheless, they were getting tried. We knew in the background, Ebola patients, when it came to trying to do something to treat them, nobody was yelling about following FDA rules. Individual hospitals just took experimental things that they could get their hands on and used them, taking risks that normally would not be tolerated in standard cancer research, let's say, and unknowns. And many people are saying, you know, when you look out there in terms of what COVID also did, you basically are allowing access to many things that have not been through anything like the FDA review process in order to get them. And you threw a ton of money at these diseases. By the way, Operation Warp Speed, one of the reasons it's speed is that the government, US government, bought all the vaccines that they contracted with from the manufacturers. So whether they worked or didn't work, the government said to Pfizer and Moderna and Janssen and other, I think Novavax, we don't care whether your damn vaccine works or not. We're going to buy a lot of it, and then you don't have any risk. And so the company said, great, and started to make huge amounts of vaccines, knowing they were going to get paid. That's throwing a lot of money at the disease, billions and billions. Again, some of the patient groups say, why don't you throw money at me? I got a terrible emergency. I'm dying, or my kid is dying. You just spent $1 zillion to develop vaccines you didn't even know were going to work. What about throwing some money at me? So let me review some of these patient-driven concerns, and they are strongly patient-driven. By the way, advocacy now goes much faster and much more intensely because of social media. Patient groups are organized in ways and talking to one another that I have never seen in my lifetime because of social media. And many of these groups are international and pressing across many fronts, whether it's a Canadian decision to reimburse a drug based on limited evidence, or watching advocacy take place in many countries to gain access to novel drugs without having to wait to go through the normal regulatory process to get into a trial as the means to get access. And a lot of patients groups are starting to say, I don't want to be in a placebo group. I don't care about that. So let's do away with that. Just give me the drug and do the study that way. So what was the state of the science with respect to all this warp speed and fast talk? It is true that a lot of money was thrown in there because of the perceived emergency, but the emergency was an infectious disease worldwide. That may merit spending a huge amount of money. With some cancer patients, their situation is awful, or ALS, but they're small numbers relative to the world population. Do we want to make similar financial commitments? Do the numbers count in terms of who faces risk of death, in terms of trying to control something that's infectious for diseases like cancer? Do we have to spend even more? Is that morally incumbent upon us from what we've seen on the research that was done for COVID? Some people are going to argue, no, it's not infectious, and you're not talking about putting the whole world at risk. That is just going to have numbers in terms of amounts spent that are unprecedented because of the level of danger. Secondly, state of the science. Did we really cut corners and go fast? Well, many of the EUA drugs that got approved, there's a long list of them. Think things like convalescent plasma, hydroxychloroquine. They all had EUA approval and they failed. So for a lot of this effort to move fast, didn't pan out. Similarly, on the vaccine side, yes, we did get vaccines much more quickly than ever anybody would have predicted, but it was partly because the vaccine science was partly in place. Some of you may know that the spike protein approach, mRNA, that was used for the COVID vaccines by Moderna and Pfizer basically had been studied in trying to find vaccines for SARS and MERS and Zika, by the way. And there was probably obscure research, but it was out there showing the safety of the model that was at least 8 or 9 years before COVID. So it isn't the case that people just woke up one day and said, hey, let's try mRNA vaccines and hope that they work. They knew from animal studies and prior work that they had something very safe. Whether it would work against COVID, they did not know. But that made them confident in terms of giving advice that it could be administered based on early trials that showed promise to a lot more people when we got to the emergency use stage. So I'm not sure warp speed in terms of thinking about should we cut corners and do what we did for vaccines or some drugs applies to cancer. We may not have the same scientific basis. If you want to put it another way, maybe we don't know enough about some of the cancers to really say it's time to try to institute an EUA approach or some other emergency permission to let people access things. We need more science. Or maybe in some areas of cancer, things look similar, and we should do what we did with the mRNA platform. By the way, one other problem in rushing to get the EUA approval to save the world from death, which I supported, there were some questions that remain unanswered. We don't know still what dose is best for vaccines. The Moderna vaccine uses a lot more vaccination dose than the Pfizer one, for example, just the way the company went. And timing. Those of you who've been vaccinated, you know you might be waiting 21 days post one vaccine, 28 days, another vaccine. Some of this comes out of animal work, but some of it is guesswork. And it may well be, as we start talking about the booster issue, because we don't have the science, that these are 3-shot vaccines, and they would work best if you got one time X, then waited 3 months, and then got one at 9 months or a year later. A lot of vaccines like HPV vaccination, polio is a 4-shot, a 4 administration vaccination. There are many that require many shots. We don't have the answers. We're going to get in a bind because of going fast and not fully following up and addressing those questions. So we don't want to fall into that trap if we're extending a model like EUA over to cancer research. The other thing that people noted is there was a lot of use, patient groups are observing, of use of surrogate endpoints in terms of saying that drug is good enough if it seems to be reducing something or building immunity levels quickly. We're going to accept that as evidence and move forward. Obviously, people say too, if somebody feels better after getting a certain administration of antibodies or whatever it might be, that should be taken into account. President Trump, when he got sick, was an example of this, sort of saying, I feel better, and I'm going to take a ride in the car, and I beat COVID because I had these antibody drugs. Indeed, some of the antibody companies are mad that they're not being used enough because patients report and doctors observe to some extent good outcomes. So patient cancer groups are saying don't demand cures, use surrogate endpoints to get speed, and pay attention to what patients are saying more. Don't tell me about endpoints that are determined by cancer researchers. You listen to me in terms of whether I feel better or I'm seeing responses that might be helpful. And some of the patient groups are saying too, our cancers are rare and ultra rare. You're never going to randomize us. You know that. Use observational studies, use different designs. That's all we've got. That'll give us speed. That'll help us out. And indeed, for convalescent plasma, that's part of what happened in the assessment of that intervention for COVID. So again, people are looking at study designs based on what happened with COVID, saying we don't have to do the traditional stuff. We have to use different endpoints. And you're not listening when patients say something works or something's helpful. You have to do that more. So I'm going to give you some conclusions about where I think cancer research is going to go post-COVID and these experiences, and then we can come back and have more discussion as long as you all are willing to do so. So first, I think, and it's funny, Andrea got into this on the newly dead thing, the patient groups are saying you better research, you have to rethink in doing cancer research risk. You need to let subjects decide, particularly those with terminal illnesses, how much risk they want to face. Just like people dying from COVID, whether they're going to get antibodies, convalescent plasma, or in some places, ivermectin, the deworming thing. Patients should have more rights to say, I want to get things that might work for whatever reason they believe it. And you have to be listening to me. I'll take more risk than the traditional regulatory process, at least in the US with the FDA and IRBs, might allow. I'm a high-risk person. My kid's going to be dead in a few years, or maybe in a couple of months. Get serious. Let us, patients or parents, make more decisions about how much risk we're willing to face in research. That absolutely is coming. We're going to see enormous pressure to make that shift. I think we're going to see more willingness to use non-randomized trial evidence, observational evidence, surrogate endpoints, to see whether a cancer intervention might be helpful because people want speed. We just saw it in the US with the approval of Aduhelm for Alzheimer's disease. That approval, which affects zillions of people, was done on a surrogate endpoint reduction, if you will, of goop in the brain. Whether that's going to help people get better from Alzheimer's or whether it's too late, we don't know. But the regulatory system is clearly listening to patient concerns and said, we're going to do this based on surrogate endpoint data rather than making sure that people's Alzheimer's, if you will, get better, which might take many years to demonstrate with these drugs. I think there's going to be a shift, and this may be one of the most important conclusions. I think people and patients are starting to say, you know, traditionally the regulatory approach in the US has been minimize risk by careful study of drugs, vaccines, and medical devices a little bit less, but drugs and vaccines through a careful incremental series of steps from animals to phase 1, 2, 3, and demonstrate that before you get another thalidomide disaster, releasing something out to the public that causes horrible problems and side effects and deaths, make sure you've got good oversight and demand good evidence before you release anything. Make sure it's safe and effective. I think we're starting to see a shift post-COVID that's going to say, I want less emphasis on preventing risk, pre-approval, pre-availability of a drug or a vaccine, and I want more monitoring and surveillance, sometimes called phase 4 for those who follow this, post the release of the drug or the device into human use. There are going to be more and more pressures to say, get me something quicker. I saw what happened with COVID and I liked it. And I'll worry about whether it hurts us by following up what happens if you give me the chance to get what I'm willing to take the risk of using. So I think we should watch in cancer research for that balance to shift. I would be advising more registries, more follow-up, more emphasis in cancer study of post-approval, whatever it is, to really be sure that things are safe, because I think the pressure is going to be strong to permit more risk before pre-approval. Last comment. More power is now being given if you allow more regulatory, less regulatory demand, as many people argue COVID did, although as I've tried to suggest that you can debate it. The funders, the insurance companies, the people who pay the bills are going to have more responsibility for deciding what they think is enough evidence to make something available. Remember, most regulatory systems just say it works, it's safe. They don't really get into the question of, and it's worth paying for. Now, more and more, whether it's Canadian provincial governments being faced with expensive cancer treatments, they may get less evidence now because patients are saying, speed it up, but they may be looking at the same evidence and saying, it's not good enough, we're not going to pay for it. And so some of the battles, I think, that sometimes have befallen regulators, like the FDA with the right to try laws, saying get the FDA out of there, I think there may be a shift more toward payers saying, regulators have approved this, you better start paying for it. And the payers saying, we don't think the evidence used is good enough. So that could be an interesting future for cancer research. Not that those battles are not intense and going on now. My prediction, they're going to get worse. I think they're going to worsen. So with that, hopefully that gives you a second landscape into the world of post-COVID cancer research. Now we've got the newly dead and 19 other things to think about with respect to where research might go. So let's see if we have any questions or comments.
Thank you so much, Dr. Kaplan. You've given us so much to think about, including these interesting and all of which are very interesting and relevant kind of questions and topics, particularly around stakeholder engagement. I found that fascinating. Just whose voices should we listen to? Who should trump? How should different voices be weighted between patients, cancer researchers, insurance companies? Lots to think about. We'll give it a moment for questions and comments to come in. I do have a question related just to emergency use authorization. And so it sounded like in relation to COVID, the emergency use authorization was partially motivated by the fact that people are dying, no options are available except for these unsustainable, perhaps, measures like quarantining. And so, of course, a vaccination was essential and the use was authorized. In relation to cancer, it sounds like part of the reason as to why emergency use authorization wouldn't apply is because more options are available, more information may be known. People are dying as a consequence of cancer, but it's different perhaps than COVID because of these other components that options are available. And so it seems like some patient advocacy groups, as you mentioned, may be trying to justify their disease, like cancer, as something deserved of emergency use authorization based on the definition of emergency used in the policy. Another approach, however, it seems, would be to potentially advocate for a different definition of emergency under the emergency use authorization, so that more diseases could potentially be classified as something deserving of emergency use. It seems like that's another way that patient advocacy groups could respond to the current state of things in relation to their disease. So I just wondered if you have any thoughts about that, broadening the definition of emergency.
Yeah, a great question. And the old FDA, pre-right to try, sort of 10 years ago, they would not have yielded anything under the existing emergency use authorization criteria because they hated it. They really meant it to be limited. They weren't giving up on clinical trials. They loved the steps they had in place. The newer FDA, pressured by legislation in the US up to the federal level that said, cut out the FDA. Legislation I didn't mention that we also have in place that says, pay more attention to real world evidence in your decisions, pay more attention to surrogate markers. That's actually part of their funding recently. They are under heat to think differently. And again, the society, or at least the vocal parts that are talking, are saying, speed it up. We want speed. So I think many groups are more than willing to do what you're suggesting, redefine emergency. I've had at least 6 or 7 different patient group advocates say to me, I have an emergency. My emergency is every day when I go home and watch my brother die. You don't think that's an emergency? Yes, I do think there will be pressure maybe to broaden the emergency use authorization definitions to say for certain subgroups with cancer, these are absolute emergencies, quote unquote. And whether that's the wisest way to do it, I think we're going to have a debate. I mean, there may be an argument that you use emergency use when you have infectious disease pandemics or something that could destroy the world or is at least easy to catch. And that's why I said the numbers may count, even if you have dying children from a rare, ultra rare disease. Sad, but if you want to build up a exemption from the usual clinical trials process to just say, okay, try it. But I'll come back to one other thing you mentioned, Andrea. There are many, many people out there now who are saying patient voices are more important. Patient voices have been heard loudly in COVID. Whether it's I want ivermectin, which I happen to think is nuts, but they're being heard, or I don't want to vaccinate because I make my choices, or you name it, whatever it is, you're here, advisory groups with lay people saying vaccines are okay, whatever it is, there is more and more entree. And bioethics has been complicit in this, trying to listen more to patient voices, recommending that we listen to patient voices. Well, the patient voices are saying, we don't like the system. It's too slow when we're sick. Speed it up. I'm not sure we all anticipated that might be the message, but here it is. So, and again, I'll concede one other point. The most vocal people are the ones who have terrible diseases. If you just have psoriasis, no one's yelling to speed up the research. So, do the clinical trial, make sure it works, blah, blah, blah. But it's in the cancer space in particular that this is vocal and strong because so many cancers are so deadly.
Thank you for that thorough response. And so questions are coming in both in relation to part 2 of your talk and also in relation to research on the newly dead, but kind of focusing on the most recent part of your talk. A question came in that says, in recent decades, various jurisdictions have expanded access to medically assisted dying. Does increasing social acceptance of this option have any bearing on how much risk we allow patients with terminal diagnoses to take on in experimental treatments?
Yes, in weird ways. So some of you know the tradition coming from England of hospice was that you provide care to someone who's dying, but they forego trying any more treatments, right? It's sort of been I accept death, we're now going to manage me palliatively, and that's how it works. I think that model is going to be put under tremendous pressure because, again, people are saying, well, I'd like to try experimental things, even if I'm in hospice and you say I have months to live, or I'm going to sign up for assisted dying at some point. Maybe I get to try some of these experimental things that are brand new before we go there. So yes, I do think it's going to shift. One other weird thing, assisted suicide raises issues about organ donation. It raises issues about who might volunteer to be a newly dead subject in research. That raises questions about how you decide to kill people, what you do to preserve their organs, allow them to be transplantable. You know, we take most of our organs now from people who are brain dead, but can be maintained on machines. Is there some mode of death that people could choose and say, well, I'd like to be brain dead and make sure I die on machines because I want to be in help research. I don't even know technically how you do all this. I'm way outside my sphere of knowledge here, but you know what I'm saying. It starts to modify what does assisted dying look like. We normally think of it as, well, I'm just going to do that because I don't want to be here anymore and I'm overburdened. Now I say, well, if I'm going to die and I know it, I'd like to help. How do I set that up?
Very, very interesting. Lots of questions there. And I'm seeing a question come in right now that we're shifting gears a little bit to think about equity in relation to cost and the funding of therapies. And so this person asks, I was wondering, how can we as a society afford more treatments that may get approved with less compelling evidence? I'm concerned that the access will become more inequitable, that some patients will be able to pay or obtain funding for these kinds of therapies, these kinds of treatments, and other patients may not. So do you have any comments just about that, around equity and around accessing treatments that get approved with less compelling evidence?
Next year, when I deliver the 41st Harris lecture, I'll probably talk about that because that is one big equity issue. I'll say this today. First, most of the decisions about reimbursement are private, not transparent, and almost star chamber kind of things where insurers meet and make their decisions. Or I've been through this with Canadian payers. You know, they have their own bureaucrats meet and they're not public. You can't say what their criteria are or what they're doing. There are many situations I know from Canada firsthand where people have connections that have been able to get something paid for because they knew the right people and knew how to lobby, whereas other people did not and did not go there. So there's inequity, if you will, in how the payers operate, need more transparency if they're going to have more decision-making power, which I think they're going to get even more than they've got. I think it's going to increase. Do we need to have, whether it's a provincial national health system like Canada or whatever the hell the American system is, whatever it is, more lay people involved in the decisions? Probably. I mean, I think limited evidence means unknown. And then you're starting to say, so how much does society want to spend in the face of uncertainty? It was easy to spend, remember, on COVID, they had complete uncertainty as to whether the thing was going to work, but they were so freaked out that they needed vaccines that they spent tens and tens of billions of dollars buying vaccines on a bet. That's a social decision that is basically no evidence. You don't know if the whole thing's going to work. So, yeah, it's a danger, to answer directly, that we're going to wind up paying for a lot of stuff. I think this Aduhelm Alzheimer's disease thing is not going to end well. There's a lot of money there, and reducing plaque in the brain is not really supported by evidence that it helps people with Alzheimer's. I don't know when to use the drug. I think that one may be an example of what we're fearful of, that we spend a lot on something that's not going to work.
Yeah, and I suppose with that one, time will certainly tell whether it was in fact the right decision. It's impossible to know. The next question is interesting. So it's asking whether you're aware of any emergency use authorization access given to a drug or a therapy for non-communicable diseases, such as a cancer, for example, or are emergency use authorizations solely provided for things like COVID?
There have been 3 uses for vaccines, communicable diseases. Anthrax, a meningitis vaccine got early approval for an outbreak. There have been a couple for drugs. I don't remember all the details, but they weren't infectious. They were like, we're worried that you're going to be exposed to something very dangerous because of maybe even a military use, so we're going to let you take this drug early. But it's usually been, as I said, high danger, related to national security issues, what the military is up to, or perception of a public health threat that's serious, not as big as COVID, but contagious.
That's great. And if you're comfortable, a question did come in, shifting back towards research on the newly dead. Is that okay, Dr. Kaplan?
Oh yeah, no problem.
Okay, that's great. Thank you for your flexibility. So this question is just around organ donation processes in various countries around the world. So of course, some countries have an opt-out system instead of an opt-in system for organ donation. And so the question is, do you see any issues pertaining to newly dead research in such countries where people need to opt out?
That's a good question too. And you're talking to somebody who has been one of the big proponents of presumed consent opt out as opposed to opt in for many, many decades. I thought that was the right way to go because I respected the idea that it's just as good to consent to opt in as it is to consent to opt out. So the answer to the question is, if you think they're morally equivalent, and I do, that is, I can be approached and say, most people want to donate their organs. Do you want to do that? And I say, no. I'm as comfortable doing that as approaching people and say, a lot of people may not want to donate their organs, but you can help a lot of folks. Do you want to do it? The consent level to me is equivalent, as long as you're honest. I mean, if you come up and say, look, Art, you're the only knucklehead in the past 20 years who hasn't let us take organs. Do you still want to opt out because you're like really a jerk if you do it? You got to do the consent properly so that people have the same abilities. If that holds, then I don't worry about it too much. You would just add on the other, you could use your organs for research, you could use your body for research, you could use your body, newly dead model for research, and you can opt out of that if you don't want to do it.
Thank you so much. And the final question right now that I'm seeing is also related to research on the newly dead. And this person, I think it's a clarification question just around what is permitted. So this person asks, if a near to death person, so a person who has not been pronounced dead quite yet, suffers from a cognitive or a psychological impairment or something where they can no longer make decisions for themselves, can family members decide for them whether to donate their organs or use their bodies for research? So perhaps this is a question, given that our systems in Canada and the US differ slightly, just for clarification and knowledge there.
Yeah, it's a good question. In the US, really families, in lieu of an expression of intent by the dying or deceased person, do have legal authority to make the donation. And if we extended that into research on the newly dead, they could say yes or no to that. I don't mind a little checkbox kind of approach to some of this. By the way, just to make, I know we're doing ethics out on the frontiers today. You probably know that some people have had children after they died by procuring sperm from the deceased man. It's not covered in the laws in Canada, the US. Are we talking about sperm donation? Are we talking about now it's possible to freeze eggs? You could probably do an egg procurement from a newly dead woman to try and make a baby. Is that something that the person would have wanted before they died? If not, does my mother, if that's who's there, really get to consent to what happens to my girlfriend or whatever it is? So my point being, you really want to try as best you can to build a system that captures what people wish to do with their bodies and their parts pre-death, pre-cognitive impairment, whatever, and update it and make sure that it's registered not just on a card, but in a computerized system that's easy to access. And I would probably say relatively easy to update. You may change your mind about some of these things over time. The authority given to families, I respect it, but morally, I think what you have to do, and this is controversial, you still, even if you had the registered wish and the intent, and it said, Andrea wants to donate everything, uterus, eggs, organs, study me, I don't care, help everybody. If the family's freaked out about this, psychologically and maybe ethically, transplant teams are probably not going to do it. The number of times I've seen somebody say, I got the card and we're taking organs, and family, you don't like it, but we're going on the card, is tiny. You really are starting to think, I got to treat the family's emotions, responses. They're partly my patients now too. And very few transplant centers, even NYU, which is obviously willing to push the edge, want a headline that says, we removed liver based on a donor card registry while widow screamed in hall. It's like, oh God, we can't do that. So yeah, they have authority, not saying families don't, and legally it's set up so that they can do it, but you're washing the psychosocial side, I've learned over the years, of what it means, the impact on the family. Really, you could have somebody die who said 18 times, I don't want anything done, I don't want you to do anything, and the family's like, we really think we should have some redemption if something happened that we can feel good about, so we're saying yes. That isn't a situation where the transplant team fights for them, right? They're saying, oh, good, okay, let's go. So it's a long-winded answer, but it's an interesting area, again, for empirical study too, to merge with the ethics. So what are their attitudes? It hasn't really been done adequately. People are a little bit flying on the seat of their pants when they talk about what families want. I mean, in our study, we knew what the family wanted. They got interviewed up and down and back. I don't have any doubts about the legitimacy of their comfort with this newly dead model. But in general, we know less than we admit.
Thank you for that. And so certainly people seem to find these topics fascinating. So thank you on behalf of the individuals who have responded to the chat box and just offering their thanks. And I will pass it back over to, and personally thank you, Dr. Kaplan. I've learned a lot and reflecting a lot upon some of the topics and questions and themes that you've drawn upon in your two-part lecture here over the last hour and a bit. So thank you. I'll pass it back over to Dr. Jennifer Bell just to make some closing remarks, and thanks.
Thank you.
Thanks, Andrea. And so in closing, I just wanted to take the opportunity to take a few minutes to thank again Bill and Pat Harris and family and friends for their continued support for this lecture in honor of their daughter Pippa. This has allowed us to engage such great speakers as Dr. Kaplan. I want to thank Andrea for her great facilitation, and for those of you that contributed the questions, thank you for doing so. And thank you also, of course, to Dr. Kaplan for coming today on behalf of all of us for such a provocative talk. I'm sure you've left many of us with, I'm sure all the scientists are thinking of ways that they could possibly use the gifts of the newly dead to advance their cancer therapy. So definitely some food for thought. I know that there's hopefully some regulators and people that review drugs that might be on the call as well. They're already grappling with how to balance uncertain evidence and high unmet patient need. It's already something that's a challenge. It continues to be so, as you say, and will get greater. We're already seeing that with advances in personalized medicine. You can't do the larger scale trials to develop some of the evidence that you need in order to gain the certainty that you traditionally have required to pass these drugs with some confidence. So of course it will just get better. So we'll have to have you back for the 41st. We need to continue this conversation. But thank you again on behalf of all of us and for everyone who joined. I wish you a good day.